Good afternoon, everyone. Today I'm going to talk about, my name is Dr. Carla Holder. I'm a general pediatrician with over 20 years of clinical experience, but now I work as a medical director for Centene Corporation in the pharmacy department. And I'm going to talk today about the disproportionate impact of type 2 diabetes on the African American community and how we can improve health outcomes in this population through health literacy. As we all know in this room, type 2 diabetes is a public health emergency. It's a killer. It affects every race and ethnicity. However, African Americans bear the burden of this deadly disease. According to the Office of Minority Health of the Department of Health and Human Services, African Americans are 60% more likely than non-Hispanic Caucasians to be diagnosed with type 2 diabetes. And they are twice as likely to die from complications related to their sequelae from an organ disease from type 2 diabetes. Some of you may be thinking, what got me into this fight? I want you to meet my sister. This is personal as well. My sister is, she has a history of type 2 diabetes, and she's had it poorly controlled for many, many years. She has multiple comorbidities, and she's been has a history of being in and out of the hospital, and even in ICU for her comorbidities and her uncontrolled type 2 diabetes. It was only after my sister realized that she needed help, and she asked my brother and I to get more involved in her care when things changed for her. Because of my knowledge and because of how much we love her, we were able to advocate for her. My sister is developmentally delayed, so she was often off of her medication. She didn't follow up like she was supposed to. She didn't have her regular visits. So I was able to coordinate with her physicians, talk to them, along with my brother, and her endocrinologist was quite caring, and her cardiologist as well, and they decided, after much, evaluation, to place her on one of the newer anti-diabetic medications called in the class of SGLT2 inhibitors. And they actually revamped her entire diabetes regimen. So the before picture, you can see that she is not well. She has the darkness around her neck shows acanthosis nigricans, which is representative of uncontrolled or insulin resistance. But as you can see, about 9 months later, she seems more confident. She has more gusto. She's stronger, and she's lost about 40 pounds, and she's more active than she has been over the past 20 years. That's what got me into this fight. And it takes more than just a medicine. It's not a miracle. We don't have miracle drugs. It also took us advocating for her. And because of the knowledge that I had, I was able to stand up for her when she couldn't stand up for herself. And in addition to the medication changes, she had her regular follow-ups, which is just as important, and her lifestyle changes, including moving more and eating better. So education is empowering, and my goal in my project it was a 3-month pilot project, but it took a whole year to implement. And the goal was to identify African American patients with uncontrolled type 2 diabetes that could potentially benefit from the newer anti-diabetic drugs. And the two classes that we focused on were the SGLT2 inhibitors and GLP-1 receptor agonists. And, just adding it to their treatment if necessary, and eventually some patients can be on just those drugs alone. Everybody's different. So the methods that we used, we primarily used an outreach campaign. So what I thought about was, with my own experience, was it was important to not only talk to the patient, but it's important that the patient needs to be educated. And if the patient can't advocate for themselves, the family needs to be educated. And also, there are providers out there that are used to practicing in a certain way and may not be using the drugs like they should. So I used a two-tiered approach, and we used managed care claims data to identify patients that met our inclusion criteria. So, like I said, our letter campaign was designed to inform both patients and their prescribing providers. In order to be included in a pilot, the patient had to have to be African American or of African descent with poorly controlled type 2 diabetes. And we define that as a hemoglobin A1C of 8% or higher, with at least one comorbidity. And examples are congestive heart failure, atherosclerotic cardiovascular disease, or chronic kidney disease, or obesity, that were being treated that were treatment naive, that were not being treated with the newer anti-diabetic drugs. So I don't have time to go into significant detail about how we did the outreach letters, but basically the goal was, like I said, to be very simple when we talk to patients about taking charge of their own health. Being educated that there are newer medicines, if they were not on them, that could help change their lives, improve their quality of life, and also improve their health. And we also encourage them to call the doctor right away and make an appointment. And on the other side, we educated the providers with evidence-based medicine and the current recommendations by the American Diabetes Association. And we also included drugs that, in both classes of drugs, the GLP-1s and the SGLT2s, that were that were preferred, and the drugs that were non-preferred. So, thanks to Dr. Lawrence and his team, we were able to put together a 3-month pilot, and we used one single line of business, and that was Carolina Complete Health. And the Centene Center for Health Transformation helped us to identify 139 African Americans from CCH that met our inclusion criteria. So the follow-up was, primarily our Centene Pharmacy Service Analytics team. They were able to track the claims data over a 3-month period after the letters were distributed. And we monitored if these members involved in the pilot program were prescribed any of the new drugs. So remember, when at the start of the pilot, they were not on any drugs. They were probably on like metformin and insulin or a DPP-4 inhibitor, and not any of the new drugs, and their diabetes was raging out of control. Let's briefly review the results. And I encourage everyone to look at the paper, which has, all the results and the charts. And I'm so excited about the outcome of this pilot program. So out of the 139 patients included in the pilot, 52% or 73 total patients, after they received the letter, were newly prescribed either an SGLT2 inhibitor or GLP-1 receptor agonist between May and August of 2023. The letters to the patients went out on May 18th of 2023. The letters to the providers, which took a little longer to get approval by the state as well as CCH, went out on June 1st of 2023. So there was kind of a week and a half lag. But of those 139 patients, 73 total patients were prescribed those newer drugs. The prescribers wrote a total of 91 prescriptions during that study period, that 3-month study period. So the project took a whole year to put together, but the actual implementation was 3 months. And as you can see, I hope you can see it, most of the drugs in both classes, the prescribers actually used the preferred drugs, which did not require a prior authorization, which is great. So just reviewing the temporal analysis, about 1 month after, like within the month after the letters were distributed, there was you can see in that blue line, those were either SGLT, we grouped them into one line, and you can see that there is a bump within the first month after the letters were sent out. So there was a significant, prescriptions, the number of prescriptions for either an SGLT2 inhibitor or a GLP-1 RA rose sharply in the initial month after the letters were distributed. So that was pretty significant. The letters went out, and within that month, there were significant amount of prescriptions written for the newer drugs. The gold line just represents all the other drugs put together that were being prescribed prior to this study. So this suggests an immediate effect of the intervention that we have to kind of dig a little deeper, which I'll go into that in a second. So finally, you can see that over the course of the 3 months, there was a gradual increase in the number of prescriptions, total of 91 over the 3-month period in these patients that were naive to any of these drugs in any of these classes. So we were very, very encouraged, and we are planning to hopefully expand this study a little further. So the bottom line for me is that knowledge is power. It's empowering, whether the patient is advocating for themselves, or like in my family, you have family members who are advocating for you. So our next steps are to monitor adherence to therapy, to monitor diabetes control, the reduction in their hemoglobin A1C levels. The goal is to be below 7%. Also monitor reduction in the advancement of comorbidities, and the number of emergency room visits and hospitalizations over time. The goal is to see, so my sister was hospitalized maybe 2.5 years ago, and that was the last time. And it was a regular thing prior to being on this medication and the changes that she made. So we're gonna be monitoring that, because as we know, that adds to cost savings for all of us. And lastly, we plan to expand the program to include patients in other regions of the country if we see that this program is indeed successful. The goal is to add a control group so we can actually see if those results were indeed accurate. And thank you very much. I want to just give special thanks to Carolina Complete Health to allow me to implement this program, and the collaboration of so many people that were very passionate about this, just like I was. So I just feel really honored to have been able to lead this team. Thank you very much.